years. And most recently, I was asked to lead the vaccine effectiveness team for the US Mpox response. And that started from the vaccine performance perspective. It started around August. And so today I'm going to be discussing some of the vaccine performance data that has come out. All this that I'll talk today will be in the public domain. It doesn't mean that all of this has been published, because actually much of it has not. Much of it is still on preprint and is subject to some alterations of numbers here and there, depending on the final publication. But I think that we're going to do a good job to hear about what the Mpox vaccine performance data is showing from around the world, not just at the United States. Now, I see a number of names that I've seen before joining this call, and so it's my pleasure to see you again and to deliver this information to VACCELERATE. And perhaps I will start by sharing my slides. All right. Good. Okay, let's go ahead. I've discussed everything on here. Let's sometimes it takes a second for these slides to progress, to go forward. Have you seen it move forward yet?
Sorry, Daniel, we see only the speaker screen. Yeah. Thank you. Okay,
there we go. I might have to test out a few times to get that to work, right? But first of all, I just as your own information, I declare no conflicts of interest with anything that I present. I'm not being paid to do this except through my normal job as a federal servant of the United States. Okay, today's agenda. I'd like to briefly go through the epidemiologic situation in the United States right now. And then we'll move on to hearing what were the recommendations for what's currently being used for Mpox vaccination prior to 2022. And those are two vaccines, as you know. JYNNEOS is one, but also ACAM 2000 was also approved. We'll talk about that. Then we're going to talk about the vaccine that was basically the predominant vaccine used during the 2022 multinational Mpox outbreak. I'll be talking about the earliest of estimates for real-world vaccine performance, followed by more quantitative vaccine effectiveness data, and then also a number of new studies that have come out based on single-dose infections, what do they look like after vaccination, as well as vaccinations that were administered following known exposure. So we call that PEP here, post-exposure prophylaxis. Finally,
sorry to interrupt, but we are still seeing the speaker slides and not the presentation mode.
Well, it proceeded to my agenda slide.
Maybe we close it and just start sharing again. Maybe that
start fresh. Sure. Let me do that. Okay. We will try it again. Okay. How is that?
That's not in presentation mode yet.
Do you see a slide?
Yep, that looks good. Perfect.
Okay. Now, Janina, tell me if it doesn't move forward next time.
I will, thank you, but it looks great now.
Okay. And so lastly, we'll go through some of the vaccine safety studies that have been completed and then a few conclusions for us. Okay. Do you see a epihistogram?
Yes, we do.
Yes, we do see that.
Okay. Okay, I think we're good. All right. So the United States Mpox response is still in action. It's set to expire at the end of this month, January, and will then certain activities will kind of merge into existing programs in a variety of ways, and those are still being negotiated. But in the meantime, the incident management system is still conducting regular meetings on assessing where the outbreak stands. And you can see here, this was the most recent data that was presented this week, and that represents all of the cases that have been reported to the US CDC as of January 13th. So fairly recently, and I think that it's interesting that we hit exactly 30,000 cases in the US. That's the official case count as of January 13th. And you can see here, these are the 7-day moving averages, the daily moving averages. You can see clearly that despite the high peak in August, that things are very low now. They are not extinguished. There are cases that are continuing to occur every day. These are very few. The numbers are very low. But what we did notice was that in the most recent post-Christmas period of time, there was a slight jump. And so what that tells us is that Mpox is not gone, and it's going to be around, we think, for some time. Noting in the red bar is August 9th. That's a day of importance because that was the day that the FDA issued its emergency use authorization. We'll talk about that in just a moment. This next slide shows the continental United States and where some of the cases are happening. Obviously, with just a few cases, it's not happening across universally, but there seem to be cases occurring in the Texas region as well as the Washington State, Seattle area. What I saw just yesterday was that there now appears to be some degree of new cases in the Los Angeles region that's not reflected here, but those cases are being tracked by the Los Angeles County Department of Health as well as CDC. What's actually very interesting, I think, is that the majority of the other big metropolitan areas in the United States that previously had seen huge explosive growth with Mpox now have very few cases. And in fact, some of these areas, Washington, D.C., New York, Chicago, and San Francisco, have few, if any, cases being reported. And so that outbreak is well under control in those regions. But it only takes a small amount of cases to start an outbreak again. So we will continue to be watching this. Let's move ahead now to vaccines. And so JYNNEOS vaccines administered and reported to the CDC. You can see here the first doses are in blue. The green represents the second doses over time. And we've administered over 1.1 million doses of JYNNEOS since the beginning of the vaccination program for monkeypox or Mpox. And so what we can see here is that very few vaccines are being administered now. And about half of those that were administered were second doses. We know that there are quite a few individuals at high risk who only received a single dose. So let's go back and talk about the Mpox vaccines that were on the market in the United States prior to 2022. And we're fortunate to have both of these already in the pipeline. The first is ACAM 2000, and this is more of an old style of vaccine. It was mainly for the prevention of smallpox. It was mainly for the occupational areas that needed preventive vaccination. And that includes laboratory workers, that includes military occupations, and it was for the prevention of smallpox. But also it could be used for other orthopox viruses, and that actually did include Mpox. And so ACAM 2000 was in the arsenal, so to speak, for vaccinations at the outset of the Mpox outbreak. But more importantly, I think here, and we're going to focus on this, is that JYNNEOS in 2019 was approved or licensed by the US FDA, and it was licensed by the EMA in 2013 for the prevention of Mpox disease. And that was explicitly mentioned in the licensure that it was for both smallpox and Mpox. As you know, this is a 2-dose series, 4 weeks apart. The original licensure was for a 0.5 ml dose, and that was a subcutaneous dose. It was believed that this was a vaccine safety profiles were better than ACAM 2000. It was less reactogenic, and there had been research showing immunogenically that it was non-inferior to ACAM 2000. So it was licensed as an alternative in adults with occupational exposure. So in the United States, at the outset of the 2022 multinational outbreak of Mpox, in June, the US expanded eligibility of the subcutaneous vaccination to persons having a known or presumed exposure to Mpox virus. And that is what we call PEP, post-exposure prophylaxis. And those are people who, we'll talk about a little bit about the definition exactly in a moment. But overall, that was an expansion of eligibility of the original licensure. In July of 2022, the WHO declared Mpox to be a public health emergency of international concern. And as I mentioned before, in August, FDA issued an authorization to allow that JYNNEOS be administered by intradermal injection at a smaller dose, at 0.1 ml per dose, to increase vaccine supply. It also allowed vaccination among those under 18 years of age, and that was still a 2-dose series. What's interesting here is this: no real-world effectiveness data on JYNNEOS vaccine against Mpox disease in humans existed prior to that 2022 outbreak. There was no human data that told us how the vaccine would work, especially how the vaccine would work in this, frankly, a novel population of gay and bisexual and other men who have sex with men, and particularly among those with immunosuppressed conditions and other factors. So this was a big unknown. There had been data that had been produced immunologically, but in a real-world experiment that we call vaccine effectiveness that had not yet occurred. And we all know, I don't have to tell you, that controlled studies are looking at safety and efficacy in 3 phases. I'm a big fan of natural history cohorts, but they have to be set up before an outbreak like this occurs, so we can observe the natural history of the immunogenesis and how the immune system reacts to this novel virus. That was not part of our equation here. What we were able to do was to look at real-world studies. The first was a simple question of, does the vaccine prevent disease in this multinational outbreak situation? That's a very basic, non-quantifiable question. We just needed to know yes or no, did it work in humans in that outbreak? And then we wanted to go ahead and plan out the vaccine effectiveness studies that would show quantification, as well as other stratifications that could help us understand if there are ways that we might be able to optimize the vaccine. So with that, we were given a very urgent charge here at the monkeypox vaccine effectiveness team to take what data existed quickly and to turn that into some way of understanding whether or not the vaccine was working in real time. And so how we did that was we were getting two streams of data. We were getting state and jurisdictional data on cases. They were coming in every day. We also had a separate system that was accounting all of the vaccinations in those states and jurisdictions for Mpox. And what we had to do is very quickly bring those two systems together, merge them on a one-to-one basis to find out who had been vaccinated and still had Mpox disease that had been diagnosed. And so that was actually quite a bit of work to get off the ground. But once we had it, we could tell over time the relative comparison of the rate of those who had been unvaccinated cases divided by the rate of those who were vaccinated cases. Those we might call breakthrough cases or failures or post-vaccination cases. That calculation is a simple measurement that is called the incident rate ratio. And that's what we used here. It's not sophisticated. It's easy to calculate once you have the data stream going. And so that's what we did. And we basically compared this. We put this up on a very rapid publication. In fact, it was, we were told, I think 10 days before it eventually became published to do this study. So this took 10 days from start to end until it was literally in print. And what we can say here is this, that we found indications that yes, the vaccine was working. There appeared to be a protective benefit from both dose 1 and dose 2 of JYNNEOS vaccine. But these results were still questionable, right? They were unadjusted. There was no causality to be inferred. And also there was clearly no information on duration of protection because people had just been vaccinated. So the length of time that we were observing was very short. And so this was a simple yes and no. Yes, it seemed to be working. And that was an important thing because, again, as you know, the vaccine was now being administered intradermally at a fractional dose to a population that largely had not been vaccinated with this vaccine before. So that was important information. It was the IRR, the incident rate ratio, was 9.6. It was significant. And so that, of course, suggested that that there was protection from vaccination. Now, this is all natural data coming in from the states. Data errors, data cleanliness, of course, is an issue. And so we did a sensitivity analysis, and we saw that even if there was 100% misclassification of core variables such as vaccination date, there was still the incident rate ratio was still a significant finding. So we felt comfortable that yes, there was to some degree indications of protection. And that information was important because we were then able to tell the community that was being targeted for vaccination, the gay, bisexual, other men who have sex with men population, that they really did need to get vaccinated. It was going to work, we believed, and that 2 doses were likely going to be the best protection. Around the same time, and now this has only recently come into preprint. In fact, I've only read the study within the last 2 weeks. This is from England, and this was another early estimate of real-world vaccine performance. This is a similar method. It's a case coverage method, and it was an unadjusted calculation where of dose 1. This is not a dose 2 analysis. It's only dose 1, but you are technically able to calculate a vaccine effectiveness quantification from this method. We had chosen not to do that with our information. We felt that the questions about causality and some other factors were so great that we chose not to issue a quantification of that protection. And the Bertrand study that you can see here felt that they could do that, and which is great. So they actually calculated among those who were under 50 years of age that the the vaccine effectiveness was 74% for dose 1, and that was significant. In why I'm highlighting the under 50 is because we are fairly certain that those who received a smallpox vaccination in infancy or early childhood likely carries some degree of lifelong immunity to other orthopox viruses. As we all remember, the Jenner vaccine produced in the 1700s was based on cowpox, another orthopox virus that was protective against smallpox, if we go back to our history. So we can also say that those smallpox vaccinations that were received prior to the early 1970s may perhaps had some prevention against Mpox as well. So what we were doing is we were stratifying, we were trying to adjust by age stratifying or age restricting that effect of a infant smallpox vaccine by looking at only those under 50 years of age. And Bertrand did the same thing. So you can see here is a 74% VE, but if you look at all adults, if you look at older adults as well, then it was a similar vaccine effectiveness, just 4 percentage points higher. Now let's move on to population-based adjusted measures of vaccine effectiveness. And these are the next level of what you might consider reliability, as well as the degree of information produced from these studies. This is an Israeli study. Arbel and Roy Zucker produced this from Tel Aviv. They were studying electronic medical records from a large healthcare organization that covered about over half of the Israeli population. And this was a population-based cohort. So this is a cohort method. They were able to find gay or bisexual or other men who have sex with men aged 18 to 42 years. And they found almost 2,000, 44% had been vaccinated. They followed these individuals for 25 days after receiving dose 1, and this was a subcutaneous dose, and found, I believe it was 3 cases emerged among those who had been vaccinated, and 15 cases emerged among those who had not been vaccinated. And so when they ran their multivariate model, they found that Mpox vaccine, JYNNEOS, subcutaneous dose 1, after adjusting for the covariates here, that vaccine effectiveness was 79%, and that was significant. So again, you see another mid to high 70% protection with dose 1 in this study as well, which is fairly good. I'll say that that in this cohort, so, and I've spoken with Dr. Zucker in particular, and I found that when they were recruiting for the cohort, Israel did it a little bit differently in terms of eligibility for the vaccine than in the United States population. And it was expressed to me, and perhaps I have it misunderstood, but it was expressed to me that when Israel was offering the vaccine, it basically was allowing men to self-select whether or not they were at risk, and thus to self-identify their risk factors, which were intimate and sexual risk factors, which are extraordinarily difficult to control for. So it's possible that this was a more broad definition of those at risk than that what you're about to see, which is from the United States. And here is the United States population-based adjusted measure. This has been published very crudely on the CDC website. You can see that here. And we are awaiting notice from a journal on whether it will be published soon. So yes, what I'm showing you is in the public domain, but there will be a lot more in the final publication. And so what we're seeing here is this. This was a matched case control study Okay, so this is a different methodology from what was used in Israel, which was that large cohort study. This was a matched case control study, again, using electronic medical records from what's called the EPIC information system. And that was included, again, over half of the US population. Our patient records are inside this database. Again, we found nearly 2,000 cases, and we found over 6,600 controls. And our controls were very narrowly defined. So this is a difference from the Israeli study. Our controls were specifically patients that had a new incident HIV diagnosis or a HIV prescription for PrEP. So this is pulled from the electronic medical record, very specific. And again, we were taking those individuals who were 18 to 49 years of age for the same reason that we discussed about the smallpox vaccine in infancy. There was a 1-to-4 match. We were able to match on a variety of topics, time, residence, gender identity, and then we also were able to adjust for age, race, ethnicity, social vulnerability index, which is a composite of that could indicate health disparities. And also we were able to adjust for immunocompromising conditions with some limited success. You can see here, after adjusting and using that control definition, our dose 1 was only half of that as seen by the Israeli study. So our dose 1 was, our VE was 37%. That was significant. Our dose 2, our full series, was a 69% vaccine effectiveness. Again, that was significant. We also found some interesting substratum of data. And the first is something that I think that perhaps we didn't expect to find. And that is that those who received their first dose as a subcutaneous 0.5 ml dose, followed by a second dose that was the intradermal fractional dose, had a much higher vaccine effectiveness than those who got the same thing. Now, this was an interesting finding. I believe in Canada, this is what their preferred mode of administration is. And so perhaps they were intuitive to understand this, but it's an interesting fact that we have not yet fully digested why that is the case. But it seems like that second dose booster seemed to have a higher vaccine effectiveness, and that has not been seen anywhere else. And it may be, it may or may not stand up to time. We don't know yet. The second interesting finding was looking at those with immunocompromisation. And of course, in this population, we know that quite a high proportion of those with Mpox also were HIV positive. And so some of those were under control. Some of those infections with HIV were under control, and some of those were not. And so what we found, we wanted to find what was the vaccine effectiveness for those with immunocompromisation, but we did not have sufficient sample size or study power to look at that. Instead, we were able to deduce that factor by looking at producing a VE result for dose 2 among those who had no immunocompromising conditions. They were not immunocompromised. Their dose 2 VE was higher than the overall aggregate estimate. It was 74%, also significant. So by that, you can infer that those who are immunocompromised had a lower VE than that. So, but we are still trying to get a better indicator for that very important factor. Okay, moving on. As you all know, creating these studies takes many, many weeks to months, many millions of dollars. to conduct on a population scale. And we did not have that kind of time. All the things that you've seen today have been produced within just a few months. And so at the same time as we were doing these other studies, we were also planning a more traditional long-term Mpox vaccine case control study throughout the United States. And you can see the locations here. These are basically just 2 cooperative agreements in the United States that we tapped into, and that is the ones in green as well as the stars. You can see those locations. So this was a retrospective case control design. Again, we are frequency matching those with who have HIV, are receiving PrEP, and also having sexually transmitted infections based on time point. And this was one of those studies and surveys where we're using cell phones to capture the information, and the results are not yet in. And this is, again, a function of these larger, more traditional studies are slower. And so we hope that we might have earliest results within a month or 2, and the final study probably would not be produced until later in 2023. One thing that I'd like to mention, though, is that as the cases have evaporated so quickly, this is an increasingly difficult thing to study, and so we don't think that we're going to hit the estimated sample size that we had projected, which means that we won't be able to look at some of the stratum that we had hoped to also understand. In other words, when you go back to what we just saw with the EPIC case control study, that very well may become the preeminent study in the United States, because this may not be able to tell us everything that study has already told us. Okay, I want to talk very quickly about post-exposure prophylaxis. And there are some studies from France, one from Lyon and one from Paris, that have been very nice, and those both have been published. You can see the citations at the bottom. Basically, what I'd like to say is that JYNNEOS vaccine is recommended among those individuals who had recently experienced direct contact, indirect contact, or prolonged droplet exposure to an Mpox case, but who had not yet developed symptoms. Now, the CDC recommends that unvaccinated people who are exposed to Mpox be vaccinated within 4 days after that exposure to receive the greatest likelihood of having a preventive effect on emergence of the disease and symptoms. There still may be some benefit to receiving the vaccine as prophylaxis within 2 weeks, but most of that benefit is likely to occur much sooner, about 4 days after exposure. The incubation period is between 3 and 17 days. There's a tail on either side, I imagine, but basically between some of the cases between 1 and 14 days after vaccination, they actually may represent infections among those who realize that they've been infected. And so that is okay. This is a vaccine that has been specifically recommended for this group. And in Lyon, they found that about 10% of those who received JYNNEOS after exposure to Mpox virus did become symptomatic with Mpox disease. And you can see the median was about 5 days after that. And also, interestingly, they found that the clinical course was mild among those who were infected, and none of those had become hospitalized after vaccination. In Paris, another hospital study found that 4% of those who had received dose 1 of JYNNEOS became symptomatic with Mpox disease during the month after vaccination. And again, among those who actually did get the disease, none experienced severe clinical disease. We also, in the United States, conducted a study of looking at those specifically who became diseased with Mpox after receiving one dose. And we compared those with the unvaccinated, and this was a larger sample. But basically what we found was we were able to produce an odds ratio chart here of symptoms in that comparison of those who had received vaccine and gotten disease versus those who had not received vaccine and got disease. And it's very interesting when we start to look at what are the symptoms that had a significant protection from the vaccine. And we can see it was chills, myalgia, fever, it was headache, malaise, and of course, a lower proportion of those who were hospitalized for symptoms. And when you compare that to some of those other symptoms, which are more specific to body parts, rectal pain, tenesmus, rectal bleeding, etc., that the symptoms that seem to be protected by one dose of vaccine are the systemic effects, the systemic symptoms, the chills, the fever. And so I think it's an interesting finding that hasn't been replicated yet, but it does appear that among those who had Mpox disease following dose 1, the vaccination may have actually attenuated severity, and it may have actually attenuated the systemic symptoms of disease. So this is an interesting piece. It's not unlike many other vaccines that could be expected to attenuate severity, but it's really, frankly, these 3 studies from France and the US are showing this. Let's move on to vaccine safety. Again, just like how vaccine effectiveness had not been evaluated formally in humans before 2022, neither had vaccine safety outside of some of the trials that might have been well before. So the first thing that was being looked at was a passive system. Anybody in the country can report this. It has some degree of inconsistency sometimes, but it can be an early first rough look at something that may be a problem that is emerging in terms of vaccine safety. What we found was that there are no unexpected safety concerns among those aged, either adults or those aged under 18 years. Anaphylaxis did not seem to be an issue. What was interesting was that half of the reports weren't actually for a clinical adverse event. They were basically talking about a vaccine administration error. Excuse me, an administration mistake. And the majority of those were related to intradermal administration of vaccine. And the most common report that had been received was for a wheal not forming following intradermal injection, which doesn't necessarily mean that it was causing any clinical adverse event. And it also doesn't mean that it wasn't a good vaccine administration. And so for those who aren't familiar with a wheal, this is what that looks like intradermally. It's simply a bump that appears shortly after vaccine. And so we had to go back and reemphasize to clinicians that could be counted as a valid intradermal administration, even if that wheal did not become apparent. And so the majority of the reports coming in from that system were basically just for a vaccine administration standpoint, not clinical problems. There have been other more formal analyses of things that really are problems, and we'll talk about those here. So myocarditis. Now, myocarditis had been found associated with other smallpox vaccines, but this was not seen with JYNNEOS vaccine. The myocarditis reports within 30 days after dose 1 were very low, 1.5 cases per million. And for dose 2, it was 3 cases per million. And I have a little asterisk because that reminds me to mention that that is actually lower than the background unvaccinated rate of myocarditis in this age group of men. So, so it does not appear that myocarditis is a vaccine safety problem with JYNNEOS. Secondly, cardiac events. Now, these were cardiac events of special interest, and it was an assortment of ICD-10 codes and also troponin values that were pulled from healthcare management files in a large system. And what they found was that there was 3.1 per 1,000 doses had these cardiac events of special interest, but upon physician adjudication, none were determined to be attributable to JYNNEOS vaccine itself. There were other explanations that were more likely. So from that, we can at least at this time can estimate that there are no significant vaccine safety issues with JYNNEOS. Let me talk a little bit about conclusions now. So what we've seen from this very, very rapidly conducted portfolio of vaccine safety and vaccine effectiveness studies is that during the 2022 multinational Mpox outbreak, JYNNEOS vaccine performed well, and it was safe in those to whom it was administered. And this is very important because, frankly, here we are in January, and these studies, many of them were started just 3 or 4 months ago. So much of the information is not out in the medical literature as a publication. Most of it is in preprint. And so, again, just to reiterate, some of these percentages may change as things go to print. There could be other things that come out that I'm not aware of. And so just a disclaimer about that. But overall, it's clear that the JYNNEOS vaccine is safe and effective in this population in the 2022 Mpox outbreak. What's also clear is that Mpox infection, Mpox disease, can still occur after receipt of a single dose. And that can particularly happen among those who are receiving JYNNEOS as post-exposure prophylaxis, PEP. And those those illnesses, those disease symptoms appear less clinically severe. And we think that a vaccination may have attenuated the severity of the disease in those instances. So there's a lot of remaining work to be done. And I'm uncertain whether or not we will have the ability to answer all of these questions now that the cases have subsided so much. One of them is that, frankly, immunologically, there is no correlate of protection for either JYNNEOS or ACAM2000. The duration of protection is unknown. And that's a huge issue because we don't know yet, will a booster dose be needed to sustain immunity in the future? We don't know to what extent those who are gay, bisexual, or other men who have sex with men are going to revert sexual and intimate behaviors, those back to some of the high-risk behaviors that led to the emergence of the outbreak in some areas. And so if that were to happen, and if immunologic response declines significantly, we don't know whether or not this can happen again. And so that is something that we don't understand, is the duration of protection. We will say that, immunologically, it appears that dose 2 will give a further long memory cell benefit, but we don't know all of the factors involved in that in this population. We don't have real-world performance data on women, children, or vaccine administered during pregnancy. That's a factor because this disease certainly is going to continue to exist in most of the world, but particularly in Africa, where it continues to be endemic. And it is endemic not only among those with high-risk sexual practices, but obviously with women, children, et cetera, and healthcare workers. We don't know the full reason why our dose 1 VE estimate differed between Israel and the United States. I suspect that much of that is probably due to the selection of controls. but we don't know all the reasons for that. Only one study has examined this vaccine performance among persons with immunocompromised situations. And there may be others out there that have not come forward yet. I hope so. And even our US study doesn't tell the full story yet. We're still trying to narrow in on whether or not we can give a better estimate for them. Second to last, only one study has examined VE within a heterologous route of administration. That's that finding that when the person received dose 1 subcutaneously and then received the second dose as an intradermal dose with a fractional volume, they actually seem to have had a better vaccine effectiveness. There could be many factors involved in that, but that's something needing further exploration. And finally, I think the question that everybody thinks of, has this outbreak been extinguished to the point that further study among this target population is not currently possible? If someone is doing a cohort study, a prospective cohort study, that's going to be a problem, as there are hardly any cases occurring. And there is not the opportunity for those to be exposed and get disease in some of these areas that just a few months ago, yes, you could have done that study. So this is going to affect things going forward. It's going to narrow the options on how we answer the other questions. And I think the biggest question we all have in the back of our mind is, will cases emerge in another population? We know that nature never throws the same pitch twice. It always is something different. And so we don't know whether cases will emerge in another population that perhaps is immunologically naive. And so this is something that we always must be on the lookout for. And that concludes my slide presentation. I'm happy to answer any questions. Thank you.
Thank you very much, Daniel, for this really fantastic presentation and update on Mpox, vaccine effectiveness and safety. I would like to ask the audience if they have any question. As far as I can see, at least from the chat room, there is one question. So Carl asks, have you had a chance to look at correlates of protection?
We have at CDC, we have not. There is a trial, an immunologic trial at the National Institutes of Health, and I'm not as well versed on what that is finding yet. I know that they completed enrollment, and I think that they are looking at this, but I don't believe that there's been any indication of a correlate of protection at this point.
Okay, thank you. I don't see any other questions, but I would like also, if I may, to comment on your presentation, how important actually, Daniel, it is to invest actually on infrastructures that can support population-based cohort studies. So this is, of course, very important at a global level. And I would like to hear your experience. How easy was it also for the US experience to interconnect the cases system with the jurisdiction system in order to provide the first, let's say, real-world effectiveness study?
Very good question. So I love cohort studies. I think that we can understand a lot from cohort studies. The important thing is to have cohort studies in place before some kind of emergence in an outbreak occurs, and so we can understand how transmission is occurring, for instance, how the immunologic response occurs, and those are incredibly important. We did not have that in the United States set up before the outbreak. I think that we need to invest in that, frankly. That's my own opinion. And what I think is this also, so it was very difficult to put together the state data on cases to immunizations. It sounds like it would be easy. It was not easy with COVID. It remains not easy with COVID. And it was extraordinarily difficult with Mpox vaccines. And there was no mandate when we started this for states to even report those vaccines. We had to go back and forth with each state vaccine coordinator and to work with them individually in order to give us the data that we could use to match with the case data that was coming through. So that was incredibly difficult to set up. So again, there was no surveillance for an orthopox virus in the United States among gay men. There was no surveillance system that was looking at that. Smallpox is gone. Chickenpox, the surveillance is very limited, and it would only be among young people. You know, there really was no system already existing to look at this. And we need to really be thinking, what could potentially erupt as the next emerging infection? And do we have adequate surveillance to capture that if it becomes a problem? And I would say that in most conditions, no, we don't. And so we always are going to be caught off guard until we start to invest in a more permanent surveillance of some of these conditions and diseases. So, and monkeypox should be a very big wake-up call.
Daniel, I fully agree with you. And it's nice to hear and gain from the experience that you had, actually. We have an additional question from Hedro. Do you give a single dose vaccination to individuals who have gone through monkeypox, or do you deem it not necessary at this point in time?
I believe, and I'd have to double check, but I believe the current recommendation is that someone with documented Mpox disease should not get a vaccine dose. Now, my question is, now that we have the supply of JYNNEOS has resolved and we have adequate supplies, I don't know whether that will be revised. And also the next question is, we can expect that someone with a natural course of disease, someone who naturally had Mpox disease, we can expect that they have robust immunity. And I think there was a brand new study, it's in preprint, and it's Spanish. And perhaps you know more about this than I do, but the study is by Sammartino, and it does indicate that there is very good immune response from natural monkeypox disease, from natural Mpox disease. So whether or not that changes in the future, I think that people who have already had disease could feel confident based on that study in particular, that they're likely to mount an immune response unless they have some immunocompromising condition.
Thank you, Daniel. I don't know if we have the Spanish group with us. Maybe they could further elaborate on this study. If we don't have any other question, I would like to ask another one based on your last slide with, let's say, the gaps that we currently have on Mpox vaccines, and specifically for children and pregnant women, since I'm also a pediatrician. So again, as VACCELERATE Consortium, we are collaborating very closely with European consortium cohorts, pediatric cohort studies like the Verdi one, in order actually to see both as a retrospective cohort, but as a prospective cohort also, if the vaccine is effective for children. But as you said, it's currently very difficult to conduct such studies based on the dynamic changes of the diseases per se. And again, this is also very important to say that we need to build the infrastructure, because really, as you said, also, we really don't know how things will progress even with Mpox in the following years. So it's really very important to focus and invest also on these populations. If you would like to comment on that, or if you are aware of any US study that is currently also progressing with focus on pregnant women and pediatrics.
Yeah, it's very important. And again, we don't know if, we don't know what the future holds. We don't know if this will somehow take hold in a different population in the future, or perhaps not, but we should be prepared for this. And In our EPIC case control study, we did find several dozen females who had Mpox disease. This was a very small proportion of all of the cases that we found. We weren't able to really produce a robust vaccine effectiveness estimate for females, but we are still trying. And perhaps even we'll just be able to show an indication of whether or not it appears to work the same way. But I don't know of any other study that's looking at that.
Perfect. We'll see. Kari has another question. Do you think there has been a lot of symptomatic disease that helped to curb the outbreak?
I think that the evidence is showing that there can be asymptomatic disease. I don't think it's anything like what we see with COVID. And we also can suspect that those who have natural disease plus those who were vaccinated and have vaccine-mediated protection, that's formed a very strong cohort of immune-protected individuals within the highest risk population. And so what I think is happening is that behavior change, radical behavior change, very quickly done, plus that those who were naturally immune and vaccinated immune, that is the crux. That's the biggest reason for the decline in the cases. And so I think that perhaps there were some asymptomatic cases or very mildly presenting cases, maybe just almost unnoticeable. But overall, I think that the largest proportion of the reason for the decline was those other reasons.
Mm-hmm. I think this was evident also from reports from ECDC that all the prompt interventions, as you mentioned, might have contributed substantially, including behavioral change for the, let's say, controlling the outbreak. If we don't have any other questions, from our side, we would like to sincerely thank you, Daniel, for your presentation and this fruitful discussion. And definitely, as the VACCELERATE Consortium, we will keep in touch with you also for future studies, I suppose.